Hi guys, good evening. Hello, hello. It's lecture time. I'm gonna give everybody a few minutes to log into the group, into the chat, and get settled here before I start lecturing. My students know that I never start lecture right on time. I like to give you guys a chance to get in, get settled, and hi Carolina. Carolina is one of my weekend students. How are you? Hi Mo. Glad you made it, girl. Okay, guys. Hello, hello. Jordan, go to the page, the Medical Divas page. You'll be able to hit play on the video to join in the live chat. Hi, Nava. Seeing familiar faces. I love it. Okay. Guys, let me know if either you can't hear me well enough or there's too much background noise because I have my fan going and my air conditioning, because my students will tell you that I prefer it to be 35 degrees in my classroom at all times. So my students have to bring jackets and heating blankets and snowsuits and hats, mittens, to keep warm in my classroom. So it's kind of funny, actually. It's funny. We should move to Alaska, Nava. Seriously. Lisa is always sweating her butt off here too. So she's it's just as funny. We're dying in the heat. And then I'm constantly going and turning the thermostat, the air conditioning back up after the administrative staff lowers it. I'm terrible. I'm terribly thermostat non-compliant at my workplace at my school. I will wholeheartedly admit to that. I'm not sorry. Alright guys, it's only 8:32. I'm going to give everybody a little bit to get in, get settled yet. Okay. People are doing all sorts of things. They have lives. Yes, it did. Guys, for those of you who don't know me yet or just learning me, Jordan is my teenage daughter who is actually an aspiring healthcare provider. We hope one day too. And she is insanely smart. And the reason that she's taking part in our live lecture today is that I am a type 1 diabetic on an insulin pump myself. So I've been diabetic pretty much my whole life. And kids of diabetics are super knowledgeable, especially kids of type 1 diabetics. So Jordan can actually answer questions and give you guys some insight on, diabetes that other people can't necessarily. She can give you insight on things that even diabetics can't, but what it's like to be the child of a diabetic. Jordan will tell you that this past Christmas Eve, unfortunately, I got really, really sick, and she had to call 911 and take me to the hospital, and I spent a week in the ICU, which was worst Christmas ever. It is what it is, but my kids have, had to deal with mom being sick a whole lot during their lifetime. So they're tough cookies, and they're kind and compassionate, and they're very knowledgeable. So makes them kind of amazing people. I know I'm a little biased on that, but I'm okay with that. Where on earth is everyone? Okay, I'm like futzing with this thing here, Nava, sorry. Alright guys, I'll give it like another 5 minutes and we'll get rolling, okay? Hey Shells, how are you babes? Hi Christina. Glad to see familiar faces, awesome. I'm futzing with this on my computer as well so I can see more. Here we go. That's what I want. Much better. Oh god, my computer's like having a seizure. Fabulous. Okay. Hi Latoya, good to see you. I'm gonna give everybody just a couple more minutes to get in, get logged in, get ready to roll. Guys, if you have friends, colleagues, peers, co-workers that are in the Medical Divas group, please invite them, have them come. Diabetes is like a big topic in healthcare, and they know so much more about it now than they did years ago. There's been huge advances over the last few years, and there's quite a few questions on the medical assisting boards on diabetes. And then if you're going forward at all, you know, into anything that's above and beyond nursing, medical assisting, you know, PA, nurse practitioner, if you're pre-med, this is all stuff that you'll be covering in school and stuff that you'll be taking exams on. So these are super duper important. Just waiting on a couple more people here. Okay, guys. Okay. Ah, Dr. Kare, nice to see you. Glad you made it. Hello. Guys, this is Dr. Kare. He's a good friend of mine. We've been friends for like 100 years and since we were kids, and he is a physician. So he's currently working for Fox Chase Hospital down in Philadelphia, doing fantastic work on cancer. So he's doing some big things down there. So he's a knowledgeable guy. He can answer questions. By all means, ask away. And just want to let you guys know that there's a bit of a lag between when you type the question. You'll be seeing me say things, but when you type your question in the chat and then you fire it off, I don't always see it right away. Sometimes it'll take like a minute to pop up. So, you know, I'm not ignoring you if you ask a question. You know, once you hit send, I'll answer it as soon as I see it. Just give me, you know, a minute for it to pop up. I'm not ignoring you. Like, I promise I'll answer all questions. And then, you know, when you ask questions too, you'll see other people can answer them as well. I have a couple of my students in here that are graduates, some on externship. Like I said, my daughter's here. She's such a great little, you know, resource, you know, from a kid's point of view. And Dr. Kari will join as well. John's not going to be here tonight. Mr. Lucas is actually at a confined space rescue class, which, like, makes me claustrophobic just thinking about it, honestly. Holy God. Somebody's got to do it, I guess, but it's not going to be me. And Ms. Turner, unfortunately, has, like, a terrible stomach bug. She's sick as a dog, this poor thing. So she's probably, you know, home sipping ginger ale with a cold compress on her head, like, feeling awful. So she'll watch this later on, though, I'm sure. So everybody wish Miss Turner to feel better soon. You got to get her back. You're the head medical diva. We need you. So all right, guys, so it's 8:40. I'm going to get started here, and you know, people will pop in and out as the lecture goes on. Feel free to invite people in as long as they're a member for the group. Oh, there's Miss Turner. Hey, our resident, you know, head diva here. Hope you're feeling a little bit better than you were earlier, girl. I know you were feeling the pain. So I'm sorry to hear you're sick. The summer's like the worst time to get sick, I swear. It really is. So anyway, like I said, people will kind of pop in and out. If you have a friend that's in the group, feel free to invite them, you know, tag people, whatever you want to do. You can ask questions in the comments. I'll answer them. Dr. Carr will answer them. Ms. Turner will answer them. Some of my students will pop in sometimes. I have another fellow diabetic in the group. She's a type 2, but she was originally diagnosed as a gestational diabetic. I won't blow up her spot. I will let her comment and say it's me if she wants you guys to know it's her, but she probably will because she's kind of awesome on educating too. She's one of my grads and is doing her externship currently and like learning all sorts of awesome stuff. So, all right, guys, so today I'm going to talk to you a little bit about diabetes, about the different types, and I'm going to give you a different perspective on things because I'm going to just briefly touch on the different types that, you know, exist and how they're different, what we do for them. Haha, awesome. Okay, Nava. It's Nava, guys. This is the other diabetic. She's a type 2 and was a gestational, so this is kind of interesting because I'm a type 1, which is very different. So my experiences are different than hers. So she can answer some type 2 questions as well. I'm all about interactive and student learning. Okay, so anyway, so everybody thinks that there is just 2 types of diabetes, right? Type 1, type 2. You have to be one of them, correct? Not at all. So there are actually several types of diabetes, not just your 1s and 2s. I'm going to talk to you a little bit about some of the myths and the stereotypes that are associated with diabetes that kind of irk me and every other diabetic out there. I also, in my diabetes groups, and I was talking to a lot of my diabetic friends about the things that are struggles for them as a diabetic that they wish that healthcare professionals know about diabetes in order to take better care of them. The reason that I wanted to do this particular topic, my students know I talk incessantly about diabetes because obviously it's very near and dear to my heart. It's something I've lived for almost my whole life, and you know, I've become very acclimated to dealing with, and it's just kind of a part of life. But you know, it's a lot of work. It's really, really hard work. So I interviewed some of my diabetic friends, posted in some groups, and I have a whole like little stack of note cards here to read you guys of things that they wish that we as healthcare professionals knew. So what caused me to do this particular topic was my experiences when I've been sick with diabetes, and how it's so frustrating to me that I'll go to a major medical center in diabetic ketoacidosis, known as DKA, which is a horrendous complication of diabetes. Typically it's type 1s that go into DKA, but this does happen at type 2 sometimes as well. It's severe, and when bad enough, it is 100% fatal if it is not treated. So it's an automatic trip to the ICU. It's not fun. And it frustrates me when I see so much ignorance and just misinformation, lack of understanding, lack of education on the very basics of diabetes from my healthcare professionals. And I'm talking like one of the nurses in my ER, the hospitalist, nurses on the floor. They just don't know. And you would think that, you know, we're trained as healthcare providers, we got to know this stuff, right? Not necessarily. And it's beyond frustrating. So type 1 diabetes used to be called juvenile diabetes. We don't call it that anymore. We haven't for a long time. Type 2 used to be called adult onset diabetes. Again, we don't use that anymore. Unfortunately, we are seeing our pediatric population that's gaining a whole lot of weight become type 2 diabetics sometimes. It's kind of terrible and scary, because then they have a long life of struggles, complications, things that they have to deal with on an easy day. It's hard enough to be a kid. It's even harder when you're different. So type 1 diabetes simply means that my pancreas does not produce insulin. If it does produce it, it's like this much and almost completely negligent, and at some point it will never produce insulin anymore ever again. There are certain enzymes and proteins that we look for when we do testing to see if this person is actually a type 1 diabetic. We're going to look at C-peptides. We also look at, you know, their glucose count when they're fasting, and what's called a hemoglobin A1C. My phlebotomy students, this is important for you guys. Hemoglobin A1C is an average of what my blood sugar looks like over the last 3 months. When you are dealing with a diabetic patient, you'll ask them how their sugars have been going, and 90% of the time they'll tell you, oh, I'm doing great, I'm doing everything I'm supposed to. But then their hemoglobin A1C comes back horrendously high, and you're like, nope, the A1C doesn't lie. So, you know, we try and bullshit the doc sometimes. Type 2, these guys produce plenty of insulin. Plenty of insulin. The problem is their bodies don't know how to use it. We call this insulin resistance. This tends to be more common in women than it is in men, and they found that it is very much related to extra subcutaneous layers on the belly. So that extra abdominal fat that so many of us women have after having babies will commonly, you know, be a cause of insulin resistance. So, and then there is gestational diabetes. Gestational diabetes is, like it sounds, during gestation while mom is pregnant. We do a glucose tolerance test during pregnancy nowadays to help diagnose this. If we see mom is having sugar come up in her urine when she goes for her obstetrician visits, well, then we're going to be looking at, okay, why is this happening? Why are we seeing glucose? So we do these glucose tolerance tests where they're fasting the night before. They have to quickly drink this really disgusting, like, thick, sugary liquid, which, you know, I've heard, like, fruit punch ones, I've heard orange ones that I hear they're all really terrible, though. One of the nice things about being a diabetic my whole life is we never had to test me for diabetes during pregnancy, so it's the one thing I got out of during pregnancy was glucose tolerance testing, so I'm not sad about that. So that we're going to try and diagnose. Now, typically, gestational diabetes should go away once the pregnancy is over, right? Not necessarily. It's becoming very common that these gestational diabetics now continue on with diabetes in their lifetime and are lifelong type 2s. Nava, my friend here, who is one of my graduates, one of my students, she had that exact thing happen. It was her, Nava, it was your 3rd pregnancy, I think, right? Or your 4th pregnancy? I don't think it was Tamara. That she had gestational diabetes, and voila, here we are how many years later, and she's still a type 2 diabetic. So Nava does what she's supposed to, you know, she's pretty compliant. I see what she eats, I see what she does, you know, she does her thing, but unfortunately, it's kind of tough. Fourth, oh, and it was Tamara. Of course it was Tamara. Tamara, stop torturing your mother. Seriously, come on. Right, and it was a new father, which makes it really interesting. So, the point I'm trying to make with this is that nothing is an absolute. Okay, yeah, we know that gestational diabetes theoretically is supposed to go away once we're done, right? Not always. We're seeing this more and more now that they return to type 2s. You will sometimes also see patients develop what I call shock diabetes. This is when the patient has a major traumatic illness or injury, like a severe infection, severe traumatic injuries that puts their body into a form of a shock and shuts down the beta cells in their pancreas, which is what produces the insulin, and turns them into diabetics. Those guys usually have it kind of hard off because that happens really fast, and all of a sudden they go from a lifetime of things being normal to whammo, I'm on a whole bunch of insulin. So you will see that sometimes as well. So that's 4 different kinds we discussed, guys, right? Type 1, type 2, gestational, shock diabetes, as I like to call it. But there's another type that a lot of people don't know about. This type is slang called type 1.5. This is this is latent autoimmune diabetes of adulthood. This is LADA. So type 1.5 are type 1 diabetics. But these guys, like every other type 1, don't have that working pancreas. The pancreas is not producing that insulin. The beta cells are lazy. Nothing's going on there. These guys were always destined to be type 1s. Everybody is born with a working pancreas. Your beta cells are functioning when you're born. But if you're a type 1 diabetic, it's at what point do they fail and then you become diabetic. I've seen kids as young as 18 months old be diagnosed with diabetes. I was diagnosed when I was very young as well. I was a kid as well. But our 1.5s, our LADAs, tend to be diagnosed in their adulthood. So you'll see them in their 20s, their 30s. It was such a bad misconception for so long that everybody that's diagnosed in adulthood is automatically a type 2. And I'm telling you that is absolutely not the case. So if we're seeing these severe type 1 diabetics that are diagnosed in adulthood, they're not type 2s. A lot of times they're these LADA, this 1.5. And it's very easy to differentiate. I talked a couple of minutes ago about running those lab results, the C-peptides. So your C-peptides will give the doctor an idea if your pancreas is producing insulin. If they are, just how much. So it's that simple. Healthcare professionals, instead of just assuming that your patient is a type 2 because you're diagnosing them in adulthood, how about you run some labs? Look at their hemoglobin A1C, look at the C-peptides. You'll probably see that these guys, when they have no other risk factors, are actually 1.5s, those LADAs. And I'm hoping as time goes on, that becomes a, more commonly known condition that people are going to recognize and look for and treat. The identification and diagnosis of 1.5s has been a wonderful thing in the diabetes community. This is because now they're getting the proper treatment. Once upon a time, these guys were all being treated as type 2s. Now remember, type 1 and type 2, well, they're both diabetes, have the same symptoms, have the same complications. They're very different illnesses. They're not the same thing. Okay, so being treated as a type 2, if you're a type 1, these people were insanely sick and living terrible quality of lives. This really is what everything is all about, is that quality of life. So now we're properly getting these people the treatment that they need so desperately. So this is a really, really good thing. Excuse me, I'm that person that always gets dry. So treating a type 1 is a little bit simpler as far as medication management goes than treating a type 2. We need insulin. It really is that simple. We are either on MDI, which is multiple daily injections of insulin, and then if we do have a patient that's a type 1 and they're on shots, they're usually on 2 different types of insulin. They'll be on a long or intermediate acting, like your Lantus, your Levemir, your NPH. And they'll also be on short-acting or rapid-acting insulin that they'll take to cover a high blood sugar or carb count for the food that they're eating. And that will give them things like Novolin R, Humalog, Novolog, stuff like that. The more common trend now that's happening, which is so much better than those shots, are insulin pumps. So I am on an insulin pump, and it is life-changing. So this is my pump. Oh, I have it upside down. This is my pump. This is a Mini-Med pump, a Medtronic Mini-Med, and this is a 530G. So this bad boy, as you can see, is on some tubing. The tubing attaches to a site that is on my stomach. So medical assisting students, medical assistants, anybody that is learning about diabetes knows that we give our insulin injections subcutaneous. That was my daughter stepping on the dog as she walked across the room. Sorry about that. They are subcutaneous injections, and we have certain sites, right? So we're often going to do the belly, the back of the arm. We can do the side of the leg, the behind. I always kind of say that anywhere that you can pinch fat, you can do a subcutaneous injection. This is, pretty easy stuff. It's the same thing for where you put the pump. So instead of giving myself shots, how many times a day, I implant every 3 days my pump site. And it's just a little needle that goes inside, and it stays there, and it has a little adhesive that it's attached to. And I hook the pump up to it, and it's delivering insulin all the time on the pump. So it gives me only one type of insulin. It's actually Humalog that's in my pump, but it does it in 2 different ways. Number one, it does what's called a basal rate. So basal insulin takes place of something like Levemir or Lantus, where it's giving me a small, steady stream of insulin 24 hours a day. With a patient with a normal working pancreas, your body is doing this all the time anyway. For me, my body can't do that, so my pump has to do it for it. It also has a bolus rate, and the bolus is to cover the food I eat and if my blood sugar is high. With an insulin pump, we have to carb count. So every carbohydrate a type 1 insulin pumper eats, she has to calculate. But it's really, really simple. I push buttons on my pump that tell the pump what my blood sugar is, how many carbs I'm eating, and then it calculates how much insulin to give. I push a button, and it fires off and goes. It's the best thing ever. There's also a piece of technology called a CGM. It's a continuous glucose monitor. I see Ms. Turner mention rotating the sites. Yes, whether you are giving subcutaneous injections of insulin or your patient is on an insulin pump, you need to rotate the sites. You can't stick in the same place all the time. You have to move around. Otherwise, you'll get sclerotic tissue, scar tissue underneath keloids you'll get sometimes. So we don't want that to happen. We want to make sure we rotate those sites. So with a continuous glucose monitor, there's actually a sensor that implants into wherever we put it. I like to put mine in the back of my arm. And it tells a receiver, which looks almost like an iPod, what my blood sugar is 24 hours a day. It is a really, really wonderful piece of technology. It's been out for a little while yet, but insurance companies haven't wanted to cover it because it was kind of expensive. Now they're covering it, and it's a lot easier to get. It's a really, really great piece of technology. So for our type 2s, these guys can be treated with insulin, but they're also treated with oral medication, your anti-hyperglycemics, anti-diabetics, like your glipizide, your metformin, Januvia, stuff like that. And we're also going to treat them with diet. So everybody thinks that diabetics are supposed to be, overweight and lazy and unhealthy, while lifestyle and weight and diet does contribute to type 2 diabetes. That's not the only thing that causes it. And that lifestyle, even poor lifestyle choices, do not cause type 1 diabetes. That is strictly autoimmune, meaning my body attacked itself. My body decided that my beta cells, my islets of Langerhans that live in my pancreas, were the enemy. So they went and destroyed them and Now they don't work anymore. So my body decided it didn't like them very much. So now they don't work. I hate when people ask me, oh, you have type 1. Is that the bad kind? Because there's a good kind of diabetes? I don't think there's a good kind of diabetes. There are times that I honestly think that being a type 1 is easier than a type 2. For me, I have so much more freedom on what I can eat, what I can do. Nava, I'm going to use you as the example on this one. So Nava takes an anti-diabetic pill in the morning. She knows that when she takes it in the morning like it's prescribed, she has to eat breakfast within the next hour or so. Let's say she gets delayed. She's stuck in traffic on the way to work. She's taking care of her kids. Doesn't get to eat breakfast. Well, now the problem is that pill is still in her system and she's going to drop. Her sugar is going to bottom out and she's going to become very low. For me, if I'm going to eat breakfast like I'm planning to and I get stuck in traffic or my kids distract me and I don't get to eat right away, it doesn't matter because I give that insulin when I eat. I count the amount of carbs that I'm eating in that meal, and trust me, we get good at carb counting after a while. It's challenging at first, but you get used to it. We look at the amount of carbs that we eat and we tell our pumps, and the pump calculates what we are going to give ourselves, which is really awesome. So for the type 2s, they don't really have that luxury unless they are on a pump themselves. By the way, guys, pumps used to be strictly a type 1 thing. Now they're putting type 2s on pumps too, and I'm really happy to hear it. So that's really awesome. So guys, no matter what specialty you're working in, no matter what it is that you're doing, what practice you're doing, what kind of hospital you work in, whatever it is, you're going to come into contact with diabetic patients every single day. It's one of the, if not the, most common chronic illnesses that you will find among any age group of your patient population. So if you work in pediatrics, you'll see it. If you work in OBGYN, you'll see it. Family practice, urology, anything that you do, you're gonna see diabetic patients. And knowing the proper types of diabetes, how they work, how they're treated is really important in order to give these patients the right care, the care that they need, the care that they deserve. So for me, it is extremely frustrating when I am getting medical care, medical treatment for an emergency in the hospital, and my providers don't know enough about diabetes. Last time I was sick and I was in the emergency room, and I won't name what hospital I was at, but it was up in New York State, I'll say that. Last time I was in the emergency room, I was in diabetic ketoacidosis. DKA happens when things happen like I get sick or I'm overstressed, and there is so much sugar in my body and not nearly enough insulin that my body starts to attack itself and break down looking for food. This causes a severe rise in the pH in the bloodstream and the body to release what are called ketones. It makes the body very, very acidic. And again, this is 100% fatal if not treated. So I was in the emergency room, I guess it was 4 to 6 weeks ago, and I was in DKA. I knew I was. When I went in, I told them, listen, I'm in DKA. I know what it feels like. This is what they normally do for me. That's important, guys. If your diabetic patients tell you, listen, I know what's going on, I know what works for me, please listen to them, because even if you are up on all of the latest trends on diabetes, I promise you, your diabetics know more than you do. They know it all. Believe me, the ones that are dealing with it for their whole lives, especially your type 1s. So I'm in the emergency room, and being that I've been a diabetic my entire life, I have crappy periphery, meaning I have terrible veins, and it's really difficult to get a line in me. I usually end up getting stuck several times, and then they decide to put a central line in me, which is not fun. So they confirmed I was in DKA, which we knew. I did not have a line yet. I didn't have an IV access yet. They were waiting for the emergency room doc to come in and start an external jugular in me, which is a peripheral line in the neck. That failed, by the way, and they ended up having to do a central line in my neck, which is, it's not fun. As terrible as you think it is, it is. So one of the nurses came in to help my nurse, who was doing a great job taking care of me and dealing with, my blood sugar issues. And he said, okay, you're going to turn off your pump now. I said, no, I'm not. Yeah, you are, because we're going to put you on an insulin drip. Yeah, you are going to put me on an insulin drip. I don't have a line yet. We don't know when he's coming in to do the line. Why would you take me off the only insulin I'm getting right now when my sugar is too high for my glucometer to read? My sugar was over 700 when I was in the ER that day. So I'm getting that basal insulin through my pump at all times. Why would you take more insulin away so that my sugar can skyrocket higher? This was extremely frustrating for me. And he got snippy with me and says to me, well, then I'm going to have to document that you refuse to take off your pump. And I looked at him, and my partner looked at him, and we both kind of said, okay, knock yourself out. So that, I felt like, was a common sense thing. Why are you going to take away the only insulin your diabetic patient is getting? Okay, ridiculous and frustrating. So that's one of the kinds of things that I do see happen. So I have a little stack here of things that diabetics, and these are mostly from type 1s, that they want us as healthcare providers to know. Okay? First of all, you cannot look at a patient and diagnose if they are type 1 or type 2. I have people say to me all the time, oh, you're diabetic, but you're not fat. You don't have to be fat to be a diabetic, people. You don't. So that one irks me. Don't just assume. Okay? Type 1 diabetes is not caused by diet or lifestyle. We did not become type 1 diabetics by eating too much sugar. That's just not how it works, okay? On a sidebar, type 2 diabetics didn't become diabetics by eating too much sugar either, so it's ridiculous and ignorant, that comment. DKA happens, diabetic ketoacidosis. It does not always mean that we are not taking care of ourselves, okay? Sometimes our pump sites get dislodged and we don't realize it. Sometimes we have infections. Sometimes we are overstressed. There are all sorts of factors that can cause DKA. It doesn't necessarily mean we're not taking care of ourselves. Type 1s want you to understand that they can do the same things 3 days in a row. Eat the same food, drink the same water, do the same activity, the same amount of sleep, give the same insulin, and still have completely different blood sugar results. Totally different numbers on all 3 days. Sometimes there is no method to diabetes madness. It kind of has a mind of its own, especially on the type 1s. Type 1 diabetics need insulin to survive. Please stop telling them that they would be way better off if they just got off the insulin, okay? They are not type 2s. Their body doesn't produce any insulin. They will die without it. Don't assume because we are sick that we are stupid. This is not the case. So when we're sick and not doing well and in DKA or having a severe low blood sugar, we cannot answer questions, with long answers. We're not going to be able to comprehend what you're asking us if it's elaborate because we're that sick, okay? Keep your questions short. Keep your questions short, to the point. Yes or no answers are good. And please don't ask your patients all sorts of questions, during a severe low. Last year, I was a patient at one of the Meridian hospitals up on the floor, and John was sitting in the room with me, and the endocrinologist came in to see me. My blood sugar was low. I knew it was low. While he was there, they came in and checked it. It was low. And that's the other thing, guys. We can feel it when our blood sugars are low and high. Please, 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 believe us. Listen to us if we tell you, hey, I'm low. Hey, I'm high. Treat it properly, because believe me, we know. So I'm having a low. I tend to get very disoriented when I'm low, which is very common. Low blood sugars will also very commonly cause patients to be agitated, even combative. Those of us in the EMS community, if you do EMS long enough, you will get those, 911 responses for patients with low blood sugars, and they are trying to kick your butt. They want to duke it out with you. It's not because they're not happy you're there. It's because they're so confused. They're so altered, that altered mental status with that severe low blood sugar, that they're just fighting. They're kicking some butt. You know, this isn't something that we can help. I have a t-shirt somewhere that says, I'm sorry about what I said when I was low. That really is what it's like. So, I have this low, and the endocrinologist starts asking me all these questions about what my basal rates are, and what my carb to insulin sensitivity, or carb to insulin ratio is, and what my insulin sensitivity ratio is. These are all settings set on an insulin pump by the endo. And I'm getting mad because I can't put two thoughts together to answer the questions, and I'm getting seriously aggravated that he's asking. And I kind of started getting snippy, and he leans over at John, and I don't know if he meant this to be a whisper, but was like, see, she's getting agitated because her sugar is low. It almost became throat punch Thursday with that comment. I promise you that did not go well for him. So moral of the story is, don't be that provider. Oh my God, please don't. Let's talk about pregnancy. Pregnant diabetics do not automatically need C-sections. Most of them can have natural vaginal births, okay? Some of them can have a VBAC as well, which is a vaginal birth after cesarean. Not everybody, but some of them can, okay? But specifically, that first pregnancy, don't push a C-section on them if there isn't an absolute medical necessity for that C-section, okay? Give them the chance. Educate them on, you know, breastfeeding. Try and support their birth plans. Teach them that they need to take in extra carbs, extra calories, and extra fluids while they're breastfeeding. Have them keeping, you know, juice boxes and snacks by their bedsides. And especially while they're breastfeeding, because breastfeeding actually uses an extra 500 calories a day, ladies. So if that's not reason to breastfeed after you give birth, I don't know what is. So it'll make you lose the baby weight pretty quickly, which is great. But it can tank your blood sugar pretty low. And yeah, see, Nava had 2 vaginal deliveries with diabetes. Nava, I don't think either one of those were complicated deliveries, right? I mean, it's not absolutely necessary all the time. There needs to be a real need. You know, I had a C-section with my first pregnancy because I had preeclampsia and Jordan had gone into fetal distress. So we did emergency and pulled her early. Otherwise, it would have been a vaginal delivery. So please, 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 they don't always need them. And this is funny because large babies. Yeah, diabetics have like huge babies, guys. And it has to do, you know, with the extra insulin and the extra glucose that we have. Jordan was born at 32 weeks. She was 6 pounds and she was 8 weeks early. So I can't even imagine like what a beast she would have been if she had gone full term. Holy cow. So this one, I always talk about this one and it frustrates me. And I feel like no matter how much we request this, it's never going to happen. It's going to be a losing battle. But type 1 diabetics on a pump admitted to the hospital don't need a special diet. We don't need an 1,800 calorie ADA diet because we are still going to carb count for every carb that we need, whether we're getting low carb or high carb meals. It's that simple. On the flip side though, type 2 diabetics do need an 1,800 calorie ADA diet, and if they are put on clear liquids for any reason, and this can be for 100 different reasons. We put patients on clear liquids in the hospital. They're nauseous and vomiting, they just had a procedure, having problems swallowing, whatever it is. Please make sure that you send them a tray that isn't full of sugary jello and sugary ice cream and juice and sugary Italian ices. Like, why are we going to give them a tray full of sugar and then complain, why are your sugars so high? I don't understand. What were you eating? Well, I was eating the food that you gave me on my tray. Really? This happens all the time to people. Sugar is not type 1's enemies, okay? It is not. Yes, I can eat that thing. Please stop asking me that. That was a quote from one of my fellow diabetics. If And this one I'm going to quote directly how this diabetic, wrote this to me. If you are not a certified diabetes educator, and these are people with advanced degrees, nurses with master's degrees, and so on and so forth, or an endocrinologist, please do not offer us advice on our diabetes. We aren't looking for your advice, and most of the time it's incorrect anyway. So please, please, please don't just offer diabetics advice, okay? Okra water, cinnamon, exercise, sunshine, vitamins, supplements, ridiculous, stupid shake diets. These things will not cure diabetes of any kind. Please, 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 like, my mom was the worst with that. Look, Kai, okra water, Oprah Winfrey and the doctors and Dr. Oz say this will cure your diabetes. Like, I can't even facepalm hard enough for that. So this stuff is not a cure-all, guys. It's not some wonderful cure you're gonna find on diabetes on the on TV, on YouTube, on Facebook. This is not good diabetes information. Mo, that's a great question. No, I didn't cover that yet, and I love that you asked it. So Mo's asking, what are symptoms of diabetic ketoacidosis? I wish any of my students from today were in my classroom currently, but they're slacking. So symptoms, oh my God, yeah, Dr. Kari, I'm with you. I can't watch Dr. Oz. I want to slap him upside the head. Like, just stub it. I can't with him. I can't. Him and Dr. Phil. I can't with him. I can't with Dr. Phil. I really can't. So, symptoms of DKA, guys. First and foremost, if you have a type 1 and they say to you, I'm in DKA, or I think I'm in DKA, please believe them. They probably are. So, when I'm in DKA, it's usually not a surprise. My sugars have been elevated, okay? Maybe it's been for 12 hours. Maybe it's been a couple of days. I will have nausea, severe nausea, vomiting. The worse the DKA gets, like the worse my numbers are, the worse the vomiting is. It'll get intractable. We have excessive, severe thirst, which is terrible because you'll want to down water as fast as possible, but then puke it all right back up again. Have that polyuria where you're just peeing constantly. You can't stop. And then, if I'm throwing up the water and I'm peeing my brains out, I get dehydrated very quickly, which then, even more complicates and exacerbates the DKA. Something you also want to look for with diabetics you think are in DKA are an unusual odor on the breath. We will often smell either fruity or like nail polish remover. We'll smell like acetone. And you can stand like a couple of feet away from a patient in DKA and smell it and go, yep, you're in DKA, I smell it. Unexperienced healthcare professionals will oftentimes mistake this for alcohol. Last time I was in the emergency room, again, I won't name this, medical center in upstate New York that I went to. Yeah, Nava, shortness of breath, but a different kind. I'm actually going to touch on that one in a minute, but you're absolutely correct. So, it was a teaching hospital, so we had the attending in there, and one of the residents, he was a first-year resident. I like to call them docklings. That's like a nursing term. So, the resident, first year, started arguing with two of the nurses taking care of me, saying, she was drinking alcohol. Her sugars are high because she was drinking alcohol. And the two nurses taking care of me were kind of dinosaur nurses like me and kind of went, are you kidding me? And the attending is shaking his head going, no. She hasn't drank a drop of liquor. And those of you who know me know I don't drink either. So she hasn't had a drop of liquor. It kind of just smells like that on the breath sometimes. So don't automatically assume that your patient is drunk. Maybe they're in a diabetic emergency. But the biggest one that I will feel, and I'll feel extremely fatigued, extremely weak. Yeah, Vipin, freaking first years, they're terrible. That's why I call them docklings. Oh my God. I lost my thought there. Oh, I'll feel extremely weak, extremely fatigued. I'll feel like I'm going to pass out when I'm standing. But the biggest thing is that shortness of breath that Nava just mentioned, which is called Kussmaul respirations. Kussmaul. And it is this, it's almost like a hyperventilating. I am breathing really deep, really fast, and I just cannot catch my breath. Walking simply from the bedroom to the bathroom to throw up for the 95th time in the last like 6 hours will cause me to cruise small. It's bad. My students know that if I'm up teaching in front of the class and I keep getting short of breath, then my sugars are probably high. There's probably ketones in my urine, and then I'm not doing well, and then they will scold me. So we look for that small respirations, okay? The reason that's happening is that it is the body's compensatory mechanism to try and reduce some of the acid in the blood. What it does is it's going to try and use carbon dioxide as that buffer. It's going to try and blow off as much carbon dioxide as it can, which is what happens when we exhale, when we breathe. So if it can get rid of something that can cause even more acid, then it's a mechanism to try and keep the body alive. So that's why you'll see that shortness of breath, those small respirations. So Mo, those are the things that you're specifically looking for, and they're scary. Okay, so listen to your long-term type 1 diabetic patients. They know what they need. They know what works. They know what doesn't work, which is even more important, okay? Every diabetic is different, every single one. There are no two diabetics that are the same, no two diabetics that will have exactly the same treatment. You need to treat them as individuals and not just as a group, as a diabetic, but as a person with that diabetes. When type 1s and pumpers are sick, do not remove their insulin pumps. Please don't do this if you're an EMT or paramedic. Please don't do this if you're a medical assistant, if you're a nurse. Please don't do this if you're a doc, if you're not actively putting the patient on an insulin drip, or you're an endocrinologist. Please do not do this, okay? Doesn't matter if the sugar is high or low. If that patient is low, the amount of insulin still delivering through that pump is very, very small. It's not going to greatly complicate things. And if they're high, like I said before, please don't cut off the only insulin that they're getting at the moment. So please, just whatever you do, do not take off that pump, okay? Please treat their highs and lows immediately when they're in your care. So if they tell you that, oh my God, I'm low, please don't take 20 minutes to go and find the glucometer and go to the bathroom and stop and flirt with the cute first-year resident and all these other things. Please go right to the glucometer, get the glucometer, check the sugar, and then when you see that it's low, if you're a tech, if you're a medical assistant, and you have to tell the nurse, the doc, whatever, grab the juice and crackers, bring it to them, then go tell the nurse or the doc, hey, listen, so-and-so is low, this was their number, I just gave them some juice, I'll recheck them again in 15 minutes, okay? This is what we need to do. Please, 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 take them seriously. Respond to them quickly, okay? This is a big one for the hospitalists, okay? If your patient is in the hospital for diabetes, if they're in DKA, they get sent to the intensive care unit because you have to be on an insulin, you have to be in the ICU for an insulin drip, because insulin drip patients get blood sugar checks every single hour, once an hour. Yes, I'm serious, okay? So when they get discharged to the floor, they come off the insulin drip. And usually what will happen is the hospitalist or the intensivist will write orders for injections until endocrinology comes in to see the patient. Once endo comes in, they're going to start that patient back up on the pump again. They're going to say, okay, you're good to go. Go put your pump back on. Let's get you stabilized for a couple of days on the pump in the hospital. Once your sugar's stabilized, then I'll send you home. That's kind of how it works. So when the endocrinologists come in and discontinue all other insulin injection orders, please do not then go and order a subcutaneous insulin injection on top of the pump. And then don't get shitty when we refuse it. This happened to me last time. I got put back on the pump. The doc was bent out of shape because my reading had been high. He wanted, to give more insulin than what my pump said. I refused the shot. And I told him, listen, I'm refusing. No offense, but you're not, your diabetes is not your specialty. This is endo work, and I'm a pumper. It's very different. So he was mad that I refused this extra insulin injection. When it was time for my next blood sugar, it was perfect. It was 112. Had I taken that extra shot that he ordered, because, you know, clearly he knows more than the endo, right? I would have been on the floor. So please, 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 like, don't order extra injections on top of a pumper's insulin that's, you know, controlled by the endo. If the endo discontinues all other insulin orders, please stick with that. Please don't go on top of it. Okay? Finger sticks, guys, are done on the sides of the fingers. Okay? The sides. They're not done here on the tip. They're not done on the pad of the finger. Both of those things really hurt. Please don't do that. They're done on the sides here of the fingers. Okay? The sides. And lastly, I'm going to read you a quote from a friend of mine who is a fellow type 1 diabetic and has been so for his whole life and is actually in fabulous control and has fabulous hemoglobin A1Cs. So this person says, "There's a difference between clinical care and real life. My needs and desires for life may, at times, take precedent over clinical perfection. Expect deviation and a plan for it. It is not a straight line." This means, you know what? Diabetics are people too. We have cheat days too. We want to have birthday cake. We want to have a glass of wine or 5 at a wedding. I don't recommend that, but we're people too. Okay? So you can't expect that perfection. It's great if we have perfect numbers all the time, but then what kind of quality of life do we have? How many things are we skipping? How many things are we not enjoying because we just refuse to do it ever? Everything in moderation is really most important. Okay? So that about wraps it up, guys. If anybody has any questions, you can post them here. Okay? I just want to let you guys know a couple quick things. Number one, congratulations to those two summer 2K17 students who signed up for the medical assisting review with Mrs. Turner. That's great. You guys are going to kick some butt. It's going to help you immensely on your exams. Okay. Another thing, I am a clinical instructor for ACE Healthcare Training Institute in Dover, New Jersey. If you're local to the institute, I teach things like medical assisting, allied health, phlebotomy, EKG, PCT. We offer massage therapy, CNA, like everything. So, you know, if you're looking to be taught by somebody like me, then you can come take my classes there. I'm a lot of fun in the classroom. We will be doing these live lectures, Mrs. Turner and I, in Medical Divas, every Thursday night from now on at 8:30. You know, I'll post the topics every week. I will let you guys know what we're covering, you know, and I will send out reminders as the weeks go on and whatnot. If there are topics that you'd like to see covered in these instructional and educational live interactive lectures, please let me know. Please message me, message Mrs. Turner. Throw ideas down in the comment section of my videos. Let me know. We can always cover, you know, any of these topics that you want to. Oh, thank you, Dr. Kari. Thank you, thank you. I've been around the block a long time. I'm kind of a dinosaur. Also, I have a YouTube channel where you can brush up on your skills no matter what nursing or allied health classes you're taking. Everything is sectioned off by playlist for topics. And it is www.youtube.com/c/that clinical instructor. And there's no spaces between the that clinical instructor. Nava or Dr. Kari, if you guys, maybe one of you could type that address into the comments so that students can click on it. Please check out the videos. Please subscribe. Please share it with your friends. I got a lot of really good stuff there. I would love for Dr. Kari to do videos on cancer, on oncology, because that's kind of his specialty. That's what he does, and he does clinical trials too, which is incredibly fabulous. And I keep trying to annoy him to get him to do these lectures and videos, but you know, he is humble and he is modest. He's like the nicest guy you'll ever meet. So he's always like, oh, I don't know about this, but he's really, really smart. And he's great. We all love him. So next week, Thursday at 8:30 is my next live interactive lecture right here in Medical Divas. As of right now, my plan is to do a part 2 to this lecture and give you guys a little bit more information about insulin pumps, and continuous glucose monitors. So thank you so much, guys, that were here for my lecture. I appreciate it. I'm going to leave this up for about 24 hours. So if anybody wants to go back and watch it, or, you know, they weren't able to make it and they want to watch it tomorrow during the day, they're able to do so. Oh, Mo, cardiology is my thing. Actually, cardiac surgical ICU is my thing. I used to work in the SICU of Deborah Heart and Lung Center in Browns Mills, New Jersey, which is a hospital that just does heart, lung, and vascular. It is a specific type of hospital. They don't direct bill their patients, meaning if the patient needs heart, lung, or vascular care and they have insurance, well, sure, we bill the insurance. If they don't and they desperately need it and they qualify, then we do all their services for free. We never direct bill them. We don't send them a bill. We'll take care of it. We'll also take patients that are very brittle, very fragile, other surgeons won't touch, that have very rare, cardiac anomalies and illnesses, and it is unbelievably fascinating and what I like to call sexy medicine. Like, it's incredible. I started out my nursing career on a telemetry floor. I did cath lab patients. Dr. Carre can vouch for that. He used to hang out with me when we worked together at the Valley Hospital while he was still, not even a dockling yet. So many years ago. So I'm with you. I'm a cardiology girl. I'm a cardio goddess. I love it. Nava really loves oncology, but when she took my EKG and dysrhythmia interpretation course, she fell in love with cardiology. So I think that she's going to become a little cardio goddess as well, which I just love to see people do this. Latoya, my pleasure. Fantastic. Share away. By all means, feel free to use my videos, play whatever you need, guys. So, all right. That's about it. If you have any other questions, I'm going to leave the chat open. Please ask. We can answer questions. Again, thank you very much. Thank you to all that attended. Thank you, Mrs. Turner. I'm sorry that you've been so sick and missed most of it, but we're thinking of you. So keep doing what you're doing, guys. And remember, dream big.